Good afternoon, honorable judges and audience. I'm Dr. Chin Yu Jie from Department of Pediatric Dentistry, Hospital Sultanah Bahiyah. Today, I would like to present my research study with the topic of dental fear and anxiety in pediatric patients, prevalence and normative data in Hospital Sultanah Bahiyah. Dental fear is commonly described as the actual reaction to a stimulus which is perceived as intimidating, whereas dental anxiety can be defined as state of apprehension prior to dental visit. These two terms is interchangeably and indistinguishable in most clinical situations. Therefore, the term dental fear and anxiety was created and had been widely used to describe the negative feeling arising from dental setting. Dental fear and anxiety is also known as DFA, have a mean prevalence of 10% in children aged from 4 to 18 years, according to a systemic review capturing the studies published between 1982 and 2006. The study from Denmark reported about 6% of DFA in children, and Taiwanese studies suggest that the DFA in children can reach as high as 20.6%. As there is no similar study in Malaysia yet, thus it is very important for dental professionals to have a clearer view of DSA in current setting. The objective in this study is to determine the prevalence and to describe the normative data of DFA in Pediatric Dental Clinic, Hospital Sultanah Bahiyah. The data was collected in June 2019 until October 2019. All fit and healthy patients aged 8 to 15 years old that attend within that period of time is included in the study. They were encouraged to complete the questionnaire form themselves with minimal help of caregiver. The total participant involved was 378. The tool used is Dental Anxiety Assessment Record, which comprises of two parts: the Modified Child Dental Anxiety Scale and the Monitor Blunter Dental Scale. Data will be analyzed using SPSS 25.0. There are two language versions of the form, which is English and Bahasa Malaysia. MCDAS form consists of 8 questions and the assessment is performed using a 5-point scale, which 1 is comfortable and 5 is very worried. This is the Gantt chart of my study. And table 1 shows demographic data of the participant. Table 2 shows the level of DFA according to the procedures. Most of the participants feel comfortable to see dentists, having examination, scaling and filling. About 26.4% of the participants is worried a lot to have the injection at the gum. And about 30.6% of participants comfortable for procedures under general anesthesia and 28.2% of them comfortable for inhalation sedation. This table shows the mean score according to the gender, which shows no significant difference between gender. Table 4 shows mean score among age group, which shows no significant difference too. Overall, the MCDAS score ranged from 8 to 36, yielding a mean of 18/45 with the standard deviation of 7.6. There are two psychology coping styles, that is monitoring and blunting coping style. Monitoring coping style is defined as attending to and seeking out information about threatening sensor, while blunting is avoiding or distracting oneself from threatening information. In this study, most of our participants opt for monitoring coping style. The prevalence of dental fear and anxiety in pediatric patients of Hospital Sultanah Bahiyah is 4.4%, which is relatively low compared to other countries, which Denmark have about 6%, Germany 5.6%, and Taiwan is about 20.6%. The highest fear score in our study shows in intraoral injection, which is 26.4%. The study in Netherlands shows higher fear score in intraoral injection, drilling, and going to hospital. Similar result had shows in Taiwanese study, which intraoral injection comes in first place, followed by drilling and head examination. In our study, we find that there is no significant difference between age level and gender. The influence of age could be partially contributed by cognitive and emotional development of the children. Study in Denmark shows fear reduces with the age increases. In this study, 30.6% of participants opt for having the procedures under general anesthesia, where 22.8% of them opt for inhalation sedation. The study in United Kingdom shows that 68% of the children choose for the procedures under general anesthesia, and 32% of them choose for inhalation sedation. It is predicted that the children who choose for inhalation sedation having less fear and anxiety level compared to those who opt for general anesthesia. The patients adopting a monitory coping style were more than those who adopting a blunting coping style. No significant differences in style of coping strategies were seen across the different dental procedures. More than one-third of the participants with the monitoring coping style felt more comfortable if the dentist comprehensively explained the scaling and polishing procedures to them. However, a higher portion of participants with a monitoring coping style still worried when receiving an intraoral injection. This study is focused on patient per se without the consideration of external factors such as parental fear and socio-economic status. Thus, further investigation about other possible factors that affect DFA such as socio-economic factor, previous dental experience, hygiene knowledge, and cultural background should be done. As for the conclusion, it is important to help children and young people to cope effectively with dental treatment. Keeping the channels of communication open and ensuring that you are an informed and flexible practitioner will help the patient to feel listened to, trusted, and this should help to facilitate for a more relaxed dental treatment for a young person, their parents, and dental team. These are my reference. Thank you.